of the session. Should we start, ma'am?
Thank you. Yes, we can start.
Okay.
Thank
So, hello everyone. Welcome to the eco session. So I request everyone to switch on their videos for better interaction. Welcome to the session. Over to you, ma'am.
Thank you, Manisha. So, sorry, my net is not very great, but we come to this nursing class for the December 2023 session, the last session for the year. And we are sincerely thankful to the team from Madurai Meenakshi Mission Trust Hospital, Dr. Annapurni, who is a senior consultant, pediatric hemato-oncologist there, and her staff nurse, the senior staff nurse, Mrs. Sangeeta. They are going to talk on an interesting, or rather a more important and a relevant topic for the nurses who are in pediatric hemato-oncology practice and training, which is on the catheter related or central line related bloodstream infection. So CLABSI is definitely a big problem for all the pediatric hemato-oncology doctors and nurses. And it is definitely a team effort for us to understand, fight, and eradicate, or rather overcome this CLABSI. So I request Dr. Annapurni to talk first from a perspective of a physician regarding the problem of CLABSI that we face in the PHO unit, and then request Ms. Sangeeta to talk about the nursing perspectives of it and how do we contribute to reduce the CLABSI menace. So I hand over to Dr. Annapurni and Ms. Sangeeta one by one. Please take over, ma'am.
Yeah, thank you.
Yeah, I just request all the participants to actively interact. Please post your questions on the chat box. And I request both of you to complete the topic by 4:50 p.m. max so that we can have a last 10 minutes for the question and answer session. Thank you.
Yeah, thanks, Dharni. So thanks to IAP PHO organizers for the chance to present, and we are happy to share. So just directly to the presentation, just a minute. So without wasting much time, so into the talk. So CLABSI, so the overview of the talk would be what is CRBSI, what is CLABSI, and what is its impact on healthcare, and followed by nursing practices to overcome CLABSI and demonstration of bundle care practices. So how does our central line gets infected? So if this is a central line which is inserted through the superficial skin into the vein. So the most common way of infection is the endogenous skin organisms. Sorry, I'm just getting some echo.
I request all the others to please mute. Thank you.
Yeah. So most common route of infection into a central line would be a skin microorganisms. So if this layer is the skin, so the endogenous skin flora, it usually tracks along the catheter and enters into the venous line. So this can cause a superficial skin infection, maybe a subcutaneous or a superficial skin infection, and also a systemic like a bloodstream infection. So this skin microorganisms can be the endogenous of the patient's wound or through the healthcare workers or any contaminant disinfectant or the dressing. And the second way of infection is the contaminated catheter hub. So again, the microorganisms can enter through the hub either from the patient's endogenous skin flora or extrinsic through the healthcare workers handling. And third route is the contaminated infusate. That is the IV fluids or blood or whatever infusion we are giving through the catheter. If it is already infected, it can cause a bloodstream infection. So this is the common routes of our catheter getting infected. So what is a biofilm matrix? So once the catheter is inserted, so if this is the vein and this is the catheter, so the outside wall and the inside wall, inner lumen of the catheter is coated with a biofilm matrix. So what is that? The organisms, so when the catheter is inserted, since it is a foreign material, the protein in our blood gets coats the catheter wall, both the outer layer and the inner layer of the wall. So upon this protein coating, the microorganisms start adhering. So initially there is one or two microorganisms getting adhered, a reversible adhesion, and then followed by a irreversible permanent adhesion, and that is what we call as a colonization of the catheter. So upon this colonized microorganisms, there is a protein matrix which is engulfing the colonies. So this protects the organism from the attack of the our own leukocytes, our own immunity. So our own immune cells cannot attack the microorganisms. That is one part, and other end is even the antimicrobials what we are giving, that is antibiotics, antifungal agents what we are giving, they also can't reach the microorganisms within this biofilm matrix. So the organisms express the clumping factors and EPS substances which binds to the proteins in the catheter. So they form a well-formed matrix which is enriched with cations, and they enclose the microorganisms. So these forms the main mechanism of resistance. So this potentiates the pathogenicity of various microbes by acting as a barrier to killing by leukocytes and less susceptible to the antimicrobial agents. And even Candida species also forms a slime-like layer and gets protected against the antifungal agents. So this is the way how the catheter gets infected and the microorganisms gets well settled within the catheter, and that is called colonization of the catheter, and they are more resistant to innate immunity and the antimicrobial agents. So what is CRBSI? So it is a catheter related bloodstream infection. So this requires specific laboratory testing, that is either by a positive culture, which is 120 minutes, that is 2 hours positive culture, 2 hours before the peripheral blood culture. So when a patient has suspected central line catheter infection, so you take 2 sample of blood cultures, one from the central line and simultaneously from the peripheral venous line, or the direct prick sample. So when the catheter blood culture shows positivity 2 hours prior to the peripheral line blood sample, so that is said to be the differential time to positivity. So if it is more than 2 hours, probably the central line has a higher colony count or a higher concentration of the organism than the peripheral blood. So that is considered as CRBSI, or the quantity of the blood culture colony count is 3 times higher than the culture in the peripheral vein. So what is CLABSI? It is the CRBSI and CLABSI are more or less the same. So CLABSI is like a little surveillance term. It doesn't require a particular proven culture positivity. It is a surveillance term or probable term for a central line infection. So CLABSI suspected when a patient with a central line has fever, chills, or other signs of sepsis without any other alternate source of infection. So they may have or may not have a local or distant sites of infection. So what is complicated CLABSI? It is if the bloodstream infection is along with endocarditis or suppurative thrombophlebitis or septic emboli or extraluminal infections, septic shock or non-resolving infection, or infection in a immunocompromised patients. What is MBI, LCBI? It is a mucosal barrier injury laboratory confirmed bloodstream infection. So this is nothing but a patient with a central line has a proven bacteremia from the central line culture, but also the patient has mucosal injury. For example, GI mucositis following chemotherapy or GVHD. So the infection could have been either catheter itself or from the migration of organisms through the GI injury. So why do we talk so about the CLABSI? So why should the nursing staffs and the healthcare workers, especially in immunocompromised patient, should worry about this central catheter line infection? So since the central line is a lifeline for patients with cancer, since they are used for multiple purposes, as we all know. So the rate of CLABSI in Indian hospital is from 2 to 9 per 1,000 catheter days. So, if a patient with a central line has CLABSI, it adds to the length of the hospital stay. That is, if the patient without CLABSI has a hospital stay of 7 days, if they have a central line catheter, the hospital duration increases by nearly about a week. And the burden of healthcare cost is all what we all worry about. So they have to pay more for the antibiotics and the duration of hospital stay. And also the 10 to 20% of the microbes in India are carbapenemase resistant. So needing to use the higher antibiotics like avibactam, fosfomycin, and polymyxin, tigecycline, etc. And added morbidity to the patient in addition to the underlying disease they have, and a higher mortality rate. So this is a study from AIMS. So they have seen their CLABSI rate in 2017 to 18, reporting 73 cases in 1 year. So their rate was 2 episodes per 1,000 line days. And the catheter in situ of more than 20 days was identified to be a risk factor. And they had more often gram-negative bacilli. So 70% of their catheter organisms were gram-negative, 20% about was gram-positive, and 5% were polymyxin. So their isolates, more of it was a Klebsiella pneumonia, followed by Acinetobacter, and in GPC, Staphylococcus aureus and Staph epidermidis was higher, and they also had a polymicrobial infection. So when seeing this antimicrobial resistance is what alarming. So 100% of Enterococcus faecium is resistant to the first-line antibiotics, and even 50% of Staph aureus are resistant to fluoroquinolones and macrolides. So and even gram-negative bacilli antimicrobial resistance was higher. So 70 to 80% of the gram-negative organisms were resistant to imipenem and meropenem, requiring a higher antibiotic. So hence, this is the reason why we all worry, and it is alarming. Central line care bundle. So what is a care bundle? It is a steps of procedures which has to be followed by the healthcare professionals. So according to research, by following a healthcare bundle practices, the CLABSI rates were reduced from 8% to 3%. Sorry, 8 to 3 per 1,000 catheter days, which is statistically significant. So they also attributed to a considerable reduction in the cost. So this is in US dollars. So $1,30,000, it has reduced to about 1,16,000 dollars. So within the bundle implantation, 71 potential CLABSIs were prevented. So this is the reason why we speak today about CLABSI. So that's all from my side as a physician. So now I request our senior sister Sangeeta to take a handover for regarding the bundle of care by the nursing.
Thanks to IRDP and DSO organization giving this opportunity. CLABSI can be prevented by use of hospital-specific bundle of care approach to with evidence-based practice, guidance for the prevention of intravascular catheter-related infection for CDC and IDSA. Bundle care approach. Assess the needle of central line. Select the CVC with minimal lumen necessary for patient care. Selecting site of central line, mid-arm pick, elbow pick, and subclavian, IJV, tunnel catheters, hemoport, Kickman, and femoral. Ultrasound guided catheter insertion by fully trained person to reduce the number of canalization, attempt to mechanical complication with all sterile precautions. Continuous education of nursing staff on strict infection control measure while central line handling. Pediatric assessment knowledge of adherent guidelines. Designated only trained people handle central line who demonstrated good competence. Maintain nursing pool. Higher proportion of patient to nurse ratio is associated with CLABSI. Barrier precaution in case of MRSA and MDR bugs. Education of patient and caretakers. Care catheter site reporting in case of any symptoms.
So, we'll now share video. video visible? Anyone?
Yes, yes. But we are not able to hear the audio, ma'am.
Ma'am, when you are sharing the video, na, you have to click on the option for share audio also.
Okay, just
blood transfusions and IV nutrients, blood sample collections, etc.
Is it audible now?
Yes, now it's audible.
Now parts of quick line. This is the parts of quick line. This is exit site. It must be covered with a dressing to prevent infection. Then start lag. Start lag prevent your pick from slipping out. Must be changed when your pick dressing. Then lumens. This is the lumens. Lumens big line have a one or two lines. This is called as lumens. Then clamp. This is the clamp. Clamp has to stay closed when the lumen is not in use. Clamp stop the blood from coming out of the pick line. Then cap. This is the cap. This is the BDQ side cap. This cap was used in close the end of the each lumen opening, stop blood from coming out of the lumen, stop germs from entering the pick, help attach IV tubing. This dressing should be changed. When it is dressing should be changed. If the dressing is loose, get wet or dirty, germs get into the area around the exit site and causes of infection. Now, things needed for things. This is the dressing tray. Then 2% chlorhexidine, Cavilan spray. Then 1 10 ml syringe, preloaded syringe. Then Heplac, BDQ site, stopcock. Then Statlock. Then chlorhexidine, Chagadam. 1 clean gloves. Now going to procedure the dressing. Of hand washing. One sister remove the older dressing. Other sister 6 steps of hand washing. Then hand rub. Inspect the line, entry site, redness, swelling, serious or bloody discharge, allergic skin reaction if any is there, inform to duty doctor and consultant. Okay. Remove the old dressing. Inner to outer. Use chlorhexidine soap swab. Cleans underline entry site circulatory motion from center to periphery for 30 seconds for 3 times. Allow the site to air dry for 30 seconds. Do not blow or fan. Remove the old three-way extension and discard it. Use new fluorescein alcohol swab. Clean the center line. Scrub the hub for 15 strokes, clockwise and anti-clockwise. Allow to side to air dry. Connect the new saline prime standalone. Then clamp the center line. Close the center line. Allow the use 2% chlorhexidine was for daily bath and reduce the CLABSI. Use the sutureless securement device. This is the sutureless securement device for fixation. Then split septum needleless to advise routine use. Use chlorhexidine sponge dressing. CLABSI is not controllable with all possible measures. Replace administration set that are continuously used, including secondary set and R1 device, no more frequently than 96 hours interval, but at least every 7 days. Replace tubing used to administer blood or blood product or fat emulsions within 24 hours or initiating the infusions. Monitor the catheter site visually or palpably regular basis while patient is in ward. This is the clean dressing. This is the soaked plus dirty dressing. Remove. Immediate reporting in case of discomfort, pain, tenderness, fever, swelling, serous or blood stains, displacement of catheter. Immediate inspection or opening of dressing in case of any above symptoms is there. Inform to consultant or duty doctors. Consent line site care of fever patient with central line. This is the line site. First one, fever in CLABSI may be associated with fever with care. Chills and rigor, signs of entry site infection, central-line thrombophlebitis, pain, redness along the line, septic thromboembolism, malfunction of catheter, or without any of other symptoms of signs. Catheter exit site, expect to be swabbed, send the gram strain and culture. If catheter is removed or suspicious CLABSI, 5 cm of length of catheter tip has to be cultured. If the hemoport is removed by suspected CLABSI, culture of port dissever or adhesion in the catheter tip. Remove the catheter in case of sign of entry site infection, persistent fever for 48 to 72 hours, appropriate antibiotic without focus of infection, central line culture positive for Staphylococcus aureus, Pseudomonas aeruginosa, fungi or mycobacteria, any catheter no longer needed. In case of early signs of sepsis, prompt catheter, blood culture has to be taken and immediate first line antibiotic has to be given. First line antibiotic coverage should be based on each hospital microbes and antimicrobial sensitivity. Take home message, all possible sterile precautions to prevent CLABSI depends on SAD bundle care by nursing staff and physicians. Continuous medical education and conscious patient care from all involved catheter healthcare persons is the key. Thank you.
So
Thank you, Ms. Sangeeta and Dr. Annapurni. I think that was very crisp and very comprehensive as well. Do we have any questions or comments from the participants? In meantime, I would like to ask, ma'am, what are all the practical measures that you take in your hospital regarding the prevention of CLABSI? Because we deal with high risk patients like transplant, AML. Sometimes doing some things to prevent are always better to have rather than having a CLABSI. So apart from the techniques, that sterile things that she has told, any other precautions that you take?
generally, this is what we had shown actually. So what we do is when the patient is in ward, we generally use a transparent dressing. Especially because that will be easy to identify the early signs of local site sepsis. So that and yearly dressing if there is any signs of sepsis. And frequent dressing and changing the hub, including the catheter hub and the IV set lines. So those CDC recommends to change the IV lines once in 7 days. So we do it often. So probably within a day or two, we change the IV line. That is one thing. Another thing is, yeah, mostly it's a common what the CDC recommends. Nothing in addition to it. Yeah. And what I would suggest for the nursing staff is that be sure that you are sterile before you start the central line handling. So do hand washing, as sister said, do hand washing and hand rub before you start handling a central line. And be sure that none of your procedure is causing is unsterile in between your procedure. If so, change the gloves as and when it is needed. And don't touch the hub or the infusion end directly with a glove or something. So try not to make it unsterile area. So that's what. Other than that, we use a chlorhexidine gel tegaderm at discharge. When we discharge the patient, and if it is not soaked, we generally dress it after only a week or so.
Okay, so is that chlorhexidine thing with tegaderm, is that
Yeah,
expensive, ma'am, or is it?
that's the chlorhexidine impregnated gel tegaderm.
Okay.
It
So,
helps us to extend the frequency of changing the dressing. And again, it is transparent when compared to the other usual tegaderm. So it is more transparent for us to inspect the site. Yeah.
okay. So there are a few questions in the chat box. So, how frequently should we flush the catheter with Hep flush?
Hep flush we practically do only when the patient is like when you're totally disconnecting the IV line, we give Hep flush. Not in between routinely. And apart from that, when we transfuse blood products, we do Hep flush once in a hour to avoid the clotting in the central line.
So you
And
use the central line for the packed cell transfusion as well?
yeah, we are using it only. You're using the
Oh,
central line only.
oh,
But we frequently flush it once an hour when the blood products are in on the line. Once
oh,
an hour we infuse Hep flush. Other than that, its routine is the pre-loaded saline flush, which is more economically and also practically better than loading it on place on time. So pre-loaded saline syringe is better.
oh.
Yeah.
And how much we need to give flush for the pediatric, and how often we need to flush, you've already answered. Is there any particular amount that should be used for flushing?
Particular amount. Yeah, if it is less than 1 year child, it's mainly based on the line what you use. So usually the volume of the lumen will be a max of 2 ml or 3 ml only. So maximum of 5 ml for whatever age it is enough. So the preloaded saline is 10 ml. So you can push the entire 10 ml for bigger kids, older kids and adolescents. For younger children, less than 5 ml will do.
Okay, ma'am. And if I can ask you to just explain, as a clinician, we will be having concerns about the CLABSI. So if you can explain for the young nurses here, at which point of time we will actually consider CLABSI? What would be the clinical signs that we would be worried about? And then the second question is regarding the practice of capping the lines if you are suspecting CLABSI versus giving the antibiotics through the line during CLABSI. These are the two schools of thought. So what do you practice, and what are all the guidelines or recommendations?
So CLABSI in general, as we had already said in the presentation, so any fever in a patient with any sort of central line, CLABSI should be suspected foremost, and especially when the patient doesn't have any other focus of infection. That is what generally. And in addition to it, especially when the entry site looks infected, it is red. So when you see the site, when it is red, tender, or there's any serous or a bloody discharge in the site along with any swelling, then obviously an infection of the entry site or the bloodstream infection should be suspected. So in that case, when you see an entry site infection suspecting, first step is remove the dressing, clean the site, and if there is any exudate coming out of it, any serous or a blood serosanguinal discharge, take a culture, swab it and send it for a bacterial culture. So if let the consultants have a look at the site also. And if you suspect that it is more severe, exudating, then ideally a line has to be removed. Or if it is a very minimal infection and provided the patient blood counts are normal, then you can try salvaging the catheter with a daily dressing or a twice daily dressing. And based on the culture's sensitivity we get, the culture growth we get, we can give antibiotics. So basically, when will you suspect CLABSI is a fever in any patient with a central line, suspect CLABSI, especially when there is no focus of infection anywhere else, and also when there is a site infection, suspected infection at the entry site. So that is what. And antibiotics, we generally, when the patient is stable enough and the counts are good, we generally infuse antibiotics through the same central line only. And regarding and if we cannot salvage the line even after 40 to 72 hours of antimicrobial agents and still the patient is spiking fever and they are severely neutropenic and persistently cultures are positive, then we remove the line. And as it was said in the presentation, if they have a Staph aureus infection or any fungal infection, candida especially, or pseudomonas repeatedly positive and you can't remove the infection or get it sterile, then it is recommended to remove the central line. And antibiotic lock, so we can lock the central line with the sensitive antimicrobial agents. There are particular antimicrobial lock guidelines are there, but not prophylactically. So once you get a culture positive, you can put antibiotic lock, but it's not recommended as a prophylaxis routinely for all the central lines. I hope I have answered your question.
Yes, ma'am. So it was read in detail. So now in general, in our unit, we try to, if at all there is a disproportionate tachycardia or an early sign of septic shock, we try to cap the line rather than removing immediately and wait for a couple of days, 24 to 48 hours to see what the culture shows. Invariably, whenever we get a fever, high-grade fever, chills and disproportionate tachycardia, usually we get a GNB or a GPC in the culture, and we see the antibiotic sensitivity and do the lock and try to salvage the line as much as possible. So, and in those situations, usually if there is shock, definitely we try to use a peripheral line. But at times, whenever it is difficult, we try to use the same line.
So as far as the patient condition is stable and blood counts are relatively stable and you expect the counts to improve within next 40 to 72 hours and you can bridge the gap, then you can try to salvage the line with the antibiotic lock. Yeah.
True. So in high risk patients, definitely we are more worried and we try to pull off the line at the earliest. So any other questions? I think we have completed well in advance, but I think we have covered the most important topics. Any questions? Any other comments from anyone else? Sangeeta? Okay. If there is no comments, then probably we'll wind off the session. Thank you so much, Dr. Annapurni and Sangeeta, for the very crisp and very useful session. And with this, we hand over to the ECHO, and the nursing classes from the IEPPHO wing will be continuing, but the coordinators will be changing from January. So it'll be announced soon who would be doing it. And it was a pleasure doing it, and we learned a lot in the process as well. So thank you so much, and I hand over to Manisha to close the session. Thank you.
So, with this, we can close this session. Thank you, everyone, for joining the session, and thank you, ma'am, for this wonderful session. I have shared a feedback link in the chat box. Please submit your feedback for the session, and thank you, everyone. Okay, bye.
Yeah,
Thank you.
Thank you.
Thank you.